and flip back video. There we go. All right, here we go. So we decided to do a buccal vitrectomy for this case. So the buccal was done under the overhead, so there was no recording for it. But we used a 41 band in this case. And the buccal was chosen to support the vitreous base and, presumably help to reduce AP traction on the eye and kind of reduce some of the, presumably with contracted retina, maybe support some of it, maybe help reduce some of the retinectomy that we might have to do in this case. Putting the trocars in, one little thing I learned from Dr. Sharma is, put the trocars in first before you pull up the band. That way, if there is, increased pressure in the eye, you begin the right away and relieve that pressure before moving forward. First step, of course, was to improve the view. So we cleared out some of this silicone oil as much as we could. As we were doing it, we realized it kept actually kind of snaking up behind the iris. So we decided to kind of clear enough, clear the posterior capsule as well on the lens, so we can get in there and clear out some of the silicone oil.
I think that's a good point. When, if that oil's been there for so long, it's always, I'm always tempted to try and clear whatever bubbles are in the AC. But the more you do that, you just liberate everything that's coating the iris, the sort of the bag and the capsule. So sometimes it's just easier to clear the oil from the back and then sort of go back. It sounds like you've got a fun surprise awaiting you back there.
Definitely. So just immediately when we took our first look, there's a large, I don't know if you see my pointer at all, but kind of superiorly bearing nasally, you see a large break, detached 360, infratemporally as well. We see another break as there. Superiorly, we see a lot of laser scar attachment points and just a significant amount of PVR membranes with like almost circumferential traction elements, radial traction elements, and so it was quite a surprise. So we're just kind of look around, see what's happening. And the first step, we wanted to identify our hyaloid, which we presume was down. So we put down some triescence. And then we're able to identify that there was kind of a ring of where the hyaloid was kind of cutting through the temporal macula and pretty close to the nerve posteriorly. The first kind of go at peeling were some freebies. I think I felt pretty confident coming straight off, and this is the first kind of pull here to pull these membranes off. But the rest of them were not going to be so easy. And so there's a lot of very sticky and wispy membranes that we're trying to clear, especially when it came off to the side of the macula. And kind of the question we had was, and when you have these kind of membranes, like how, especially when you're working near the macula, is how hard to kind of, how aggressive to be when we're pulling and tugging in these areas, and trying to find that right Goldilocks tensional point was kind of a challenge we had with this case.
So Hadi, let me ask you a question or two. So you removed a couple of these pre-retinal membranes first, and then you're going in with a diamond dusted now, correct? To try to find some additional ones. Right. But it seems like you're going in some areas you're already peeled. Was there some suspicion that you had more?
So we peeled, I think, well more nasally when I get those two membranes off and a little bit inferiorly. But I think as it came across to the macular area and bearing temporally, when we tried to grab things, it was kind of like a wisp that would come up. We didn't really get any nice membranes. And so we're trying to find maybe an edge that will allow us to find a plane that we could kind of grab and dissect off and cause some relaxation of our retina in this case.
And then you didn't take any oil out with a viscous fluid extraction line, correct? Or did you take did you start with, so all the oil that was in the eye was emulsified?
That's correct. That's correct.
So this patient probably already had oil in and now oil out. And the rest of that was probably some leftover oil, right? Because it wasn't it wasn't filled with oil. That's why the B scan looks so good. It wasn't a complete oil fill. Is that what you guys saw?
So that was, I think that was exactly what happened. I think she had the oil out, and I think that for some reason the history wasn't very clear to us. I think in the office that had happened, but it would make sense that she had this a decade ago, and they took the oil out last spring probably. And then what happened was it was an incomplete oil removal and had a lot of emulsified remnants that ended up sneaking around both in front and behind the retina. And throughout the case, I didn't show in my edited video, but every few minutes, as you're kind of working and manipulating the eye, we kind of lose the view, we pop, bring the lens up, see had a bunch of oil that was liberated and is now floating in front to our cornea in front of the AC. We cleaned that out again and kind of get back in the game. And we had this kind of back and forth that was happening as we were kind of liberating things, cleaning up membranes, twerking the eye around, and then some of these bubbles would kind of find their way into the anterior chamber. And so
Hadi, were you doing air fluid exchange? When you said you cleaned it out again, what were you doing? Just like air fluid again, or
no, we didn't do it. Yeah, it wasn't air fluid. It was, when I mean that I clear it out, I mean kind of what I was doing before, which was going to the AC through our paracentesis and trying to aspirate these bubbles out because they would come a little bit at a time. So we didn't do an air fluid exchange in the beginning of the surgery.
And Hadi, the patient is pseudophakic, is that correct?
That's correct.
All right. So I'll ask you later whether or not you should take the lens, but a couple of the questions that are coming up in the chat here is what kind of instruments to use to maybe engage membranes. And I'm a personal fan of the diamond dusted. I think you're going to show us some other techniques, but did the diamond dusted help you? And then go from there.
The diamond dusted has helped me in the past. I think in this case, I was maybe not receiving so much help from it as we were trying to get these membranes up. And I think, my level of kind of force or aggression was increasing with time, trying to really get something up and get it going. I will show some other instruments we use a bit later on that were ultimately more effective in helping us find these membranal planes. But I think in this case so far, as I'm showing here, we're really, I think, aggressively using the diamond dusted and not really coming up with a whole lot until maybe some more time went by and we finally got a little bit up and we tried to peel it. It was kind of wispy again, and we kind of had this cycle going on and on.
Hadi, what about using some steroid or something to help identify this, or some other stain? Was that considered?
It's something that different Metrotelca is always taking a second to restain and put some more dye or steroid back in the eye to kind of think and allow yourself to have better visualization. We did not. We did start with the steroid, but we did not end up reinstilling it into the eye.
I'd hook it up like an IV. Like I'd be pouring steroid into this eye, only because I think you're as you're pointing out, you're looking for edges, you're scraping, and you build a little frustration into that as well. So we would kind of keep the triessence and probably a diluted 3:1. You don't want it super thick. And the benefit I find of that is that, yes, it'll help you with the posterior membranes, but then when you get to the periphery ultimately, and then you find your big anterior loop action going on, like it'll have this gentle, like studded, crystals. And then you're like, I know now what I need to unzip. So just something to consider.
And I'd say two other things. One is that I know you sped up the video, but I think sometimes it's being a little more deliberate with the diamond, pushing down a little bit more and slowing down the movement. I know you sped up the video and that's clear. The other thing I'd say is even when the diamond is not picking up something, that actually is helpful. Most of the time, if there is a membrane, at least you'll catch something, you'll see the retina move. So when you don't see that, I think you're aiming superiorly, and I hope that's the case. I think it means that most of that area is cleared off. So now you can kind of move to the next thing. And we have a couple of comments about maybe using some other dye, maybe some, blue and such, but let's let you keep going and see what you get.
Yeah, I mean, I guess, okay. Yeah, it would be interesting to hear what other dyes people have found helpful in these cases.
I think we're going to hit dyes with a couple of the other cases. So let's see what you got. So what are you doing here, Hadi?
So this is basically the macula, and we see this kind of membrane go around it, and we're just trying to. It looks like there's an edge there, and we're trying to grasp it as gingerly as possible. Just get the membranes without trying to delaminate the nerve fiber layer. And to your point, that it is when we see the Tano not bringing anything up, we started to ask ourselves, and I think it's come up in just a second here. Are we still sure there's membranes here? And so we did use another technique to try and identify those in just a second. So we were trying to find our membrane and just we weren't able to grab anything. So we said, you know what, we have a built-in intraop OCT. Let's just take a look here and see if we can identify the membranes using the OCT. We can already see it on this slice here. I think this the second you'll see like another little bit of membrane.
Does OCT show, Sunil, does intraoperative OCT show you emulsified subretinal silicone oil? Because that's what the ultrasound showed.
Well, I think, again, it depends. Here you won't see it because the focus is too high. I mean, if you're going to see oil droplets, sometimes you can see it on OCT. I wouldn't say you will definitively see it. Right now, you have no idea what's happening in the subretinal space right now. I think there's a point of, could there be subretinal PVR? I'd be surprised if there wasn't, right? But
I mean, I think looking at that ultrasound, like there was something like crappy underneath the retina. So I'm just wondering, because even as Hadi's doing a nice job, with the scraper, there's this convexity of the retina, and it's just sitting there, and it doesn't look like there's like a ton of giant star folds. Like I'm really wondering whether maybe there's not that much pre-retinal, but there's a whole bunch going on either far anterior or subretinal at this point.
All right, so I'm going to disagree with you, and I'm going to say that yes, there is definitely subretinal, but I think that just the shape of it tells me there's still some more pre-retinal stuff that I think is there, and now you're searching for it. Right now, it's, to me, the shape temporally, especially. I think that there's something that's kind of grabbing, especially like if you look at where some of those folds are right now. To me, it just seems like there's something else here. So I would use forceps or a lighted pick at this point. And I think, to your point, Prithvi, I would put down perfluoron at some point to see how the retina flattens, to get an idea. I think that gives you an idea of the shape, whether it's going to settle, and start giving me my mental plan of whether I need to do a retinectomy.
So I agree. I think that there was a pretty dense membrane here, is what I was thinking. Hey, sorry guys, I've putting the little one down, who's not feeling well. But I was, so there's some dense membranes there. I could tell just the way the retina was moving and the way that it looked. And it felt pre-retinal. And I was pretty convinced that we hadn't gotten it off enough yet that I'm pretty sure there was some subretinal component. I knew that there was a component of that, but that membrane in the fovea, I think, was pretty significant. And this, I think Hadi will show it next, what we did.
I wanted to mention, I agree that I think it's important to get as much of that pre-retinal membrane off as you can before you address anything subretinal, because once you've made a retinectomy and kind of started flipping things over to get the subretinal stuff out, you're not going to be able to do much on the pre-retinal surface. So I agree with Sunil and Sumit that you need to get that all off first. And I think one technique that works well a lot of times if you have star folds is to take the serrated forceps and just go right into where a star fold is and kind of just grab and almost try to grab the retina itself, because you're usually going to grab something on the surface and then gently pull and see if you start to get a membrane and the rest of the retina is not coming up too much. And often you can get a membrane that way.
Yeah, I'd agree. And I love the serrated forceps too. I think the Ilum forceps, as some of the comments have said, more likely to tear membranes too. Serrated seem to be the way to go often for these.
One more comment, something else I've found helpful in cases like this is to stain with ICG or brilliant blue, if that's your choice. Once you're ensured that the vitreous is up or the hyaloid is up, and then consider peeling the ILM under PFO to really get those epiretinal membranes, to make sure you have that plane if you're not sure where exactly to grab the membrane itself.
All great points. I think a lot of great techniques here. Let's see you go for it, Hadi, because we haven't even gotten to the good stuff, right?
All good stuff. So so then to find that we still have some preretinal membranes here, we start trying to, well, we went back and grabbed what we could, but we did have some deep grabs, and we ended up losing our view. So we cleaned our epithelial off here, and trying to. So here's where we try to grab at that big fold. Let me try to get that point right here. Sorry. And as we did so, I think it was almost like a little, deep, and trying to just grab it and take it off. And as you can see, it caused some heme, and end up having to get a little cautery, and it's just there on the supratemporal aspect of our macula. So it was, eventually we did get some of it, but it was, again, trying to titrate that force and trying to find out how to get the membranes without trying to grab too much of our retina. And I think when we kept trying to use just the forceps alone, we end up realizing, maybe we need a little bit of extra support here. So then we switched to our lighted pick and forceps combination, which was, I think, really helpful and helping to, again, get some of these planes dissected off and create more of a broader sheet that we could work with.
Hey, Hadi, talk us through, because you're first year retina fellow, you're doing this. Tell us how you did it. Like, tell us what it felt like.
So it's the retina itself. It's a lot of different things to feel here, right? So first of all, the tension and the contraction in the retina itself, it's definitely something I wasn't really familiar with, and trying to, again, it has some give, it has some stiffness to it, and you're trying to, again, not just grab, at the right place and move the pick in the right plane to help dissect things off, and again, try to pull up and not push down too much that you want to go through your retina, but just kind of find the right amount of tension as I'm moving through it. And of course, getting used to the entire dynamics and flow of how the lighted pick is lighted, of course, the cone of light in front of it, and just kind of teasing away these membranes in this way. I think I was starting off definitely too gingerly. I was kind of, in the beginning of this case, I was kind of very gently, almost like I'm trying to do, regular macular peel, just kind of grabbing at things very softly and moving around and trying to, grab things. It wasn't really working. And then titrating, I tried to a little bit too heavy. I did a little deeper grab, and then found the right position where I could kind of pull things off the right direction, with the right tension.
I think those are all great points. And I think that the hardest thing to do is with both hands, understanding that you need to keep that forceps putting tension on the retina. Like, it has to be under stretch for that membrane. Otherwise, the use of the lighted pick is nearly useless, because you don't have any counter traction, and the retina is not under stretch. It's a really difficult thing to do, especially your peripheral. You think you may already have had something deep and a break in your posterior. It can be quite terrifying. I'm seeing a lot of comments, and I think that this is kind of changing in evolution, is using brilliant blue these days, like to see if there is kind of an edge that you've been kind of roughing up with the diamond dusted scraper to that point, or even with your forceps, and then now using that edge as the kind of the basket, the handle, sorry, the bucket handle, to be able to identify your PVR membrane. I've used it too, and it's actually, it can be impressive when you have a break already. Then you can kind of take that forward to get to your starfold.
Yeah. Yeah, definitely terrifying is one way to put it. But again,
I don't think anyone said terrifying, but that's okay. Go ahead, man.
Well, I think I heard that in there, but sure. You see, we did get a little bit of the handle up here, like Mr. Jay was saying, that we found that handle, and I was able to kind of work with that, and some of it come off, and again, keeping under tension and trying to. So let me get back here. The handle, and trying to dissect. Again, get the vectors going the right direction with the light pick.
Yeah. That last one was a good one. Is there room for PFO at this point as a third hand, or are you too posterior, worried about it going under?
I think we felt that we were a little bit posterior about it going under still at this point. Dr. Sharma, correct me if I'm wrong.
I think what happened is we were able to get it out to like the temporal edge of the macula, and then it was just like this thick adherent blob that couldn't separate anything, couldn't find a plane anywhere. And then at this point is where we talked about doing a retinectomy. And then the question became how big. And I thought I saw some talk in the chat, and I agree that somebody made a comment that if you go past the inferior meridian, you got to go at least 180. You never want to leave the edge of the retinectomy down between kind of like 4 and 8. You always want to try to get past that point. And so I agree with that. And the question here was, though, that we'd have to get much higher in order to get that edge that's still very adherent off, because you can't really leave adherent membranes behind either, right? So Hadi, what was the thought process? This is your first time doing a retinectomy, right?
I think it's probably my second one, but yeah, basically.
I think I got that pleasure with Hadi. I think that pleasure was all mine.
Yeah. And so
I got lots of pleasure from this one.
yeah.
We'll see.
So we can just back it up here. We're moving forward, and we'll see a little bit zoomed out here. So we had our a large tear over here, and we had another tear up in this infratemporal area, and the one we showed previously, supranasal. And so I think the idea was to, while preserving as much as we can, kind of circle around and try to leave a little superior tongue here if we could, while kind of commencing a retinectomy along this kind of line of, latitude, if you will.
So let's take a step back. How do you decide when it's time to do a retinectomy and when you can avoid it, right? So that's the bigger question instead of what we did specifically here.
Sure.
When do you, what are reasons to do it versus not?
I think when you have a significant contracture of the retina, in case PVR cases in particular, we're unable to, maybe if you have too much contraction, you can't relax that retina anymore to fit the contour of the globe. And it's not going to lay down
it basically AP contraction, right? So when the retina is either too stiff peripherally so that it won't sit flat, or when it's contracted where no matter what you do, because of the amount of membranes that are there, it's not going to sit flat when you try to put PFO in. And somebody had mentioned putting PFO down now before starting, and the concern was that it would go subretinal because of that posterior break, and that makes the case much more challenging. So let's see what we did with the retinectomy, since we do have to move along. But let's go ahead and see. So when you're doing the retinectomy, I guess what are the key things, or what are the different ways you could do it?
So I think the first step is to kind of use cautery to kind of outline where we want to go, but also to really cauterize really well the retina, so that when you do start cutting and using the vitrector, you are able to not end up losing our view, or even worse, having blood slide backwards and go posteriorly behind the macula. So good hemostasis to begin with is really important, or preventive hemostasis, if you will. It's one thing that is kind of in my mind as I'm thinking about this stuff. And so, of course, sped up a little bit here. And this is kind of the path that we had discussed we were going to take to.
So one of the things I told you was no right angles, right? You want to make it a nice, smooth, curving retinectomy. So it made you go back and fix that area because it was a really sharp angle there. Right. And I agree. I like to put some PFO down to stabilize the posterior pole, but you got to make sure that it's not going to go subretinal. And so that's one of the things that we were worried about.
Exactly. Yeah, the obtuse angles. And so we put some PFO down, just enough kind of to support the macula, and then proceed along with a retinectomy.
Hadi, where are you cutting in relation to the diathermy? Are you cutting anterior to it? Are you right in the middle of it? Like, where are you going?
So what I'm trying to do sometimes and what I do are different things. So I think what I aim to do is cut along the line cut in the middle of my cautery, because then I know that I have left a bit of each end that's been cauterized, and that I will kind of ensure to the best of my ability that I'll have a good degree of hemostasis. You know, and we'll see an instance where maybe in the few seconds here where I'm unable to follow my line very well. But that's kind of the approach I take. Stay in the middle of
I
the
think
line.
a broader retinectomy edge with cautery is always better, at least for me when I'm training fellows how to do this. Hemorrhage is your enemy in this, so having a broader retinectomy mark with diathermy, I think works better, especially over major vessels.
Yeah, I agree. And I think that when fellows are learning, I think it's easy for them to just eat all the cautery, eat everything that's diathermized. So I try and sort of caution them against that. I'm like, I'd rather have you be anterior to the line than eat the entire diathermized line, but it's definitely a learning process.
Yeah, I like extra diathermy along the larger vessels, and taking about, you know, I always say that leave 2/3, take 1/3, so that you don't go posterior to it. Because if you aim for that, you'll probably get half and half, or like 90% of it that you end up taking. But you can easily go backwards. And the keys here, how do you avoid getting posterior to where you actually want to be, is because you're going to do it here, right? So go ahead and let's see that part.
Yeah, Hadi, let's keep moving on our talks. We give other people an opportunity to present.
So right about here, go back to that. It's a bit too quick. I'm coming around right here anterior to this break. As I proceed to the break, we'll see that I think my vacuum is a bit too high, and that allowed, and I mean I wasn't moving as peripheral as I should have, and so I end up retinectomizing a little more posterior to the line where I wanted to go. And so we'll see that happen right about there. So of course, we had some bleeding, hemostasis, we cauterized the edge, and lucky we were able to pull out some of these clots that had formed.
But that's where the subretinal, the PFO bubble to protect the fovea is important, because that's what prevents it from going subfoveal. We were limited in how big of a one we could put because of that posterior break, though.
Correct.
And you kind of saw when you have that peripheral PVR and that retina's like kind of folded in, when you cut in that area, if your vacuum's just high enough, the whole thing is going to rotate. And that's what happened. It wasn't you went backwards or Hadi, it was your angle of your cutter and then how much vacuum you were using, and then that just snapped up the retina.
Snapped up, right.
Yeah, you just your settings were a little too high.
You needed to turn the cutter away too.
Yeah. So just I tend to use a lower vacuum on this. I really bring it down, and fellows love the Ferrari and pushing really far down the pedal. So I usually put you in first gear or second gear with the vacuum, so you can't go up too high.
Yeah, I think I was too excited about how well I had done the other side.
Don't worry, we knew you were gonna mess it up. Don't worry about it, man. We always will. Keep going, man. Sorry.
All right, so extracting the clots. You're almost here towards the end. So trying to peel this last little piece here, because we were wondering whether or not we could preserve it in our retinectomy. Unfortunately, this was just some membranes that we could not end up getting off the retina. Put a little more PFO down. We tried to see if it would flatten with us. We lasered around, made sure our retina was flat underneath, had some condensation of our lens. So a nice little trick was to put some viscoelastic to help improve the view, and try to dry around, and ultimately and ensure we end up retinectomizing around that as well, because we weren't able to get it flattened due to the membranes that had formed and the way it was just kind of diluted.
I think two big questions here. Do you do 360? And if you do 360, do you take off the buckle?
So I think it's always, I think when possible, to preserve a little bit of or to avoid 360s, because you have to maintain, I think, the rotation of the retina or prevent it rotating on you, is my understanding. And the buckle, I think in this case, I think I would keep it. I think we kept it only because it supports your vitreous base a little bit around, you know, the fur part that's still attached, I think it has an effect with kind of the flow dynamics posteriorly.
Yeah, I think once you're about 270, buddy, it's 360 all the way. Once you're 360, pull the buckle. don't leave hardware in. It's not going to help. The hardware is not going to help right now.
Yeah, I think, you know, if you've got an area that's still attached, you can still rotate, and the inferior portion can still rotate. We left it in her because I was actually more worried that that area was super adherent and we'd have to go even way further back. And so that's why I left it in her. But yeah, if once you're past 270, just take it 360 usually, not always, and then take off the buckle if you're going to do that. We left that area because it was so adherent there that I didn't want to go even further posterior.
I would say cyclotorsion is not her biggest problem. I think we'll try to maybe finish this case because just like any PVR case, it goes longer than you think, and we have several others. We're going to probably hit some similar topics. So
just oil it.
Nice job, Hadi.
Can I ask one question?
Anytime.
Yeah. So it didn't appear that there's any emulsified subretinal silicone oil, because I didn't see anything weird coming out of the subretinal space. Is that right? So if that's the case, what were we seeing on that ultrasound?
Yeah, good question. It looked
so
like
there was already a break. I was wondering if it didn't pop through that break once we got in the eye, because there was a decent amount of oil that came forward once we got in there. So I'm wondering if it just popped through and came through the break. So that's one possibility. That's the only thing I can really explain for where it went.
Yeah, maybe maybe we just didn't see that when that happened in the video.
Mm-hmm.
Or it was an optical illusion because there's oil in the eye. I mean, that's the thing is with ultrasound, right? With oil in there, if you have enough emulsified oil, it's sometimes not clear what layer it's in.
Hadi, did Sumit buy you a milkshake after that? Because that was really good surgery. That was a tough case, man.
Yeah.
Well done.
Nice job.
But attending and fellow to deal with me.
Okay, so these cases are going to get collectively worse when it comes to PVR. So on that cue, coming back to the West Coast, I'd like to introduce our second presenter today. Suzanne Michalak is a first-year retina fellow here at Stanford. She did her residency at the Duke Eye Center and is presenting a very complex case that she did with Ehsan Rahimi, one of our faculty members. And moderating from our side is Dr. Stephen Smith, who's a clinical assistant professor of ophthalmology and innovator supreme, who will be taking us through. So Stephen, Suze, go for it.
All right. Hi, everyone. Awesome job, Hadi. That was great. Okay, so my case, I have no disclosures. Mine is a 42-year-old guy who had an open globe after he was hit with a screw in his left eye. It was a pretty big laceration, 9 millimeters. Did a very light B scan beforehand. It showed a dense vitreous hemorrhage, but no RDs. So the open globe was repaired. And we followed him pretty closely with serial B scans. Then between weeks 2 and 3, we didn't see him for a week. And I'm going to go just a forewarning. I know I was short on time. So we're going to talk about surgery number 4 today, but this is just the background of this patient's care. So this is what we saw week 3. It was a closed funnel RD. So we went in that night to repair it, did a lensectomy, but left the capsule. We're very optimistic at this point. Did a 360 retinectomy, as we just talked about, benefits, some of that, and then couldn't get the retina to flatten, so left PFO in for 2 weeks, positioned the patient on his back as much as possible, and then came in, removed the PFO, inserted silicone oil. Things were looking pretty good. There were a few PFO bubbles underneath the retina, as you can see here and here, a few in the macula, and there was a little bit of traction inferior to the nerve, but retina was flat, retinectomy was sealed. So we kept on following him. This is the OCT showing it's attached. And then 2 months later, it was still attached, but it was developing what looked like posterior PVR in this.
Wait, Suze, wait. You left PFO in the eye? What kind of sacrilegious thing is that? Did you just forget to take it out? Can you talk us through that?
Sure. So when we kept on trying to go from PFO to silicone oil, every time we were removing the silicone oil, the retina would refunnel. So even tried like direct PFO to oil exchange, and it wouldn't stay flat. So, and I think Dr. Rahimi's on, but essentially, I think the only option that we could think of was to either just leave the oil in and see it funneled, and just accept that it was going to be like that, or try to leave PFO in and hope it would stay flat and reattach under PFO. So we went back.
Why did you think it kept funneling? Was it you guys knew there were more membranes, but you just couldn't peel it in that first surgery? Was it like die another day? Was that your thought process?
I think it was die another day. Yeah, I think we were happy to even get it somewhat flat under PFO. And it had already been a pretty long surgery at that point. So. And
then did you guys have like subretinal PVR that you were peeling in for this first surgery? Because usually when it's a closed funnel, you have like that napkin ring right around the nerve. And so you can be peeling all stuff in front of the retina, but if you don't get that napkin ring, then it's not going to flatten.
I don't remember subretinal bands at that point. I remember a lot of subretinal hemorrhage that we removed all of it. I mean, it had been at least, like I was doing all of the B scans for this patient, and I really don't think the retina had been detached more than a week at this point. It was like a very obvious change in the B scan. So I don't think that there was a lot of subretinal PVR, but as I'm saying too, it wouldn't flatten either. So not sure.
I think it's a baller move. The fact that like you guys, when you couldn't get it to flatten, you didn't know what to do unless you just wanted to keep cutting more and more. Live to fight another day. I think that's great.
Yeah, and I would jump in there and say I think that's a really important thing as a surgeon. You have to know when enough is enough, right? And there's kind of an internal clock that I think we all have, and some people are like fine picking at things for 5 hours, and other people say like, hey, it's been 2 hours and we're not gaining here. So what can we do so that we don't turn a bad situation into a worse situation, right? To try to save the eye. And so, yeah, this isn't ideal, but I think in this case, as we'll see, I think it worked, and I think that's a really good lesson for fellows who are going to go out on their own, and you're going to have cases like this where you like can't get it to the exactly how you want it, and then knowing how to get out of the eye without being a debacle.
Great point. All right, so then surgery number 3, we put in the silicone oil, developed PVR. This is showing.
So when you went back 2 weeks later to take out the PFO, did you just do an exchange? So did you take out the PFO, put in the oil, or did you have to do more peeling? What did you do at that point?
When we took out the PFO, the retina was attached, so we just put in oil and kind of as Prithvi was saying, live to fight another day. Just kept our fingers crossed and got out of the eye. It was a short surgery. Okay, so video. Let's see. I tried for this one not to speed up many parts of it, so I think it's gonna look very slow in comparison. But I am happy to speed it up if people feel like it's too slow. All right. Sorry.
Did you think you're going to need to do more retinectomy at this point in this case, or were you just going for a peel? And
we were just going for peeling and also removing the capsule. Because at this point there were 360 synechii to the capsule that we had left in the eye. So we started by moving the silicone oil, looked around, saw the retina was still attached. At this point, it had been about a month since we had seen the patient in clinic, and 3 months since the surgery to remove the silicone oil. So we took out the oil, put on the contact lens, stained with brilliant blue, as people were saying before, we can talk about in this case. Saw an edge once we stained with the blue. Like I said, I didn't speed this up, but I can. So I usually have to grab multiple times because I don't want to go too deep into the retina on the first few grabs. These were using the ILM forceps, as I know there were a few of the comments that said maybe max grips will create less shredding.
But here you're going after ILM, right? Are you trying to get ILM, ERM? Is this? I would keep the ILM forceps for this part.
So I think I was going in the center and it wasn't coming. And then eventually I went kind of more peripherally, and then it came as a really nice sheet. And I think this was the
That's
retinal membranes. I
Great
don't think
job.
this is ILM. Sorry.
Yeah, this is beautiful, and I think the point in going slowly here is to show that technique, which is patience, right? And one of the things that I see a lot when I'm operating with fellows, and I remember when I was a fellow doing the same thing, is the tendency to be like, oh, it's taking too long, and then grab like 16 times and actually make no progress, as opposed to slowing down and actually getting a good bite and then kind of really tenaciously peeling. So I actually think it's a really beautiful peel and really, really nice technique there.
You stayed very parallel to the retina. I think that's a really important point when you're posterior, and then you started curving your hand up, which is important because sometimes you forget that the eye will curve. So we don't like when the forceps hit the retina. So that was really well done. That was nice.
I also really like how you sort of marched along the membrane to sort of loosen it. I think that was really nice, and your control was great.
Thanks. I have great mentors. I'm very lucky. And we got it all off as one sheet, and then it was still attached. And then we stained again, make sure to see if we had gotten the ILM, and then we peeled ILM. The goal is to peel most of the ILM off the macula. Also, because not the major point of this case, but we wanted to remove those subretinal PFO bubbles as well from the macula. Saying a third time to make sure we had actually gotten.
If I can just jump in here, Suze, for a second. So I actually don't use Brilliant Blue. I'm still old school. It's an old man that I am, and I use ICG. So it looks to me like, and again, I wasn't operating in this case, but it looks to me like Suze peeled what it looked like ILM, right? Came up as a nice sheet, and then she just stained again and she peeled again ILM, right? So there's not two ILMs here. So I assume that what was peeled the first time was the posterior hyaloid face. Does Brilliant Blue stain hyaloid? Does anybody have any experience there? Or it's also possible I'm disoriented and maybe that was a totally different area of the eye, but to me, it looks like we've peeled twice from the same general area. Any comments? Has anybody seen hyaloid stained?
ICG dye definitely stains hyaloid. So I would probably assume that Brilliant Blue does too, but I don't know for sure.
Peter Tong thinks that it doesn't stain hyaloid.
So I think it stains. I do think it stains like ERM. I think it's very hard to know sometimes. I think this is, not surprisingly in this case, it's going to be multi-layered, right? So I think this is. I think your first one feels like ERM to me, but you would think ILM would be coming up with that just because it's so adherent. But again, it shows you that we don't always know everything. That's why you sometimes have to double stain. Yeah.
So how long were you staining for? Like in the first place, so it looked like it stained pretty well, and I still see some bits of stain. So more stain is always better until you get toxicity, right? So I guess I just wonder, like, if you're pretty sure you got ILM up, how much more did you need to see what was left over? If the goal is just to find membrane versus hyaloid.
I think to answer your first question, you're sitting for 2 minutes every time, which is what I've seen most people do. I think the main goal was that this is his fourth surgery in a pretty short amount of time, and really didn't want to have to take him back again. So that's why we stained a third time to really try to get all of the ILM off the macula.
That's fair.
And Peter's asking, why not sprinkle Kenalog onto it first? Again, I wasn't there for the case, but I would assume that the assumption may have been that hyaloid was already up, and then do Brilliant Blue afterwards after the hyaloid was up. Although in this case, I'm not sure that the hyaloid was up. I can't tell for sure. And personally, I actually sometimes prefer to stain with ICG. As I mentioned, I don't do Brilliant Blue typically, and getting the ILM flap and then using that to help get an ERM up, which is just personal preference. And I find sometimes that I'm more effective that way. But certainly I think in this case, triessence could have been used as well.
And the main benefit of that would have just been to need to stain less frequently with Brilliant Blue to use the triessence. Just make sure I understand.
Exactly. Yep.
All right. So once we did get all the ILM off the macula, sorry, I lost the. Okay, then we noticed these peripheral membranes that were actually not very adherent. They're pretty ezy to peel. So I got those started with the ILM forceps. Then use the vitrector on aspiration, or combination of aspiration and cut, to remove these peripheral membranes. Here we're kind of shading them after we got them off the retina. And then this is just a short video of the subretinal PFO removal.
And Zeus, can you tell us what you did there? What that looks like
sure.
a cannula?
We're using a 41 gauge subretinal needle to try to puncture the subretinal PFO bubble. I cut out a large part of this video because it was very long. I'll be honest, I did not do this part because I tried multiple times to do it, and I don't think I had the strength to push hard enough, I think, to break through the bubble, because I think it took a surprising amount of force to get subretinal and actually get the PFO out. Before this, we had, used the flex loop and made sure that we really had all the ILM off, because it seemed harder than it should be to get it out with the subretinal needle. We also tried to move it out of the macula with the flex loop, which hadn't worked. We had tried a bunch of other things.
Yeah, I'd love to hear, like, was this on, so did you have this on direct aspiration, and you were using, what was your vacuum? Like, I mean, in the chat right now, people are talking about a couple of different ways of doing it. The key for me is, the key for me is if you're going to do it trans through the retina and go over it with suction, I think having the ILM off makes it easier for it to come to you. So I think, this is the technique I do to grab it. I just go down with a soft tip right over it and suck, or I trim, someone just mentioned it, a 41 gauge cannula, and try to get a sharp edge and puncture through. Those are the two ways I do it.
Make it sharp. I see. We had tried aspirating over, and we were pretty sure all the ILM was off and it wasn't working. So we felt like we needed some way to, like you said, either puncture it either by aspiration or by a needle.
I think the larger ones are harder to do with just suction. I think the small ones are easier to do with suction, but when you have a large one like you did there, I think you actually have to like engage it into the subretinal space. So that's a larger bubble, like a tiny bubble. I think you can get to fly up to you. Otherwise, you do have to kind of engage it in the subretinal space.
Let's see. I'm going back too far. Okay. Then we lasered all the areas of heme and some other areas of the retina on the edge that looked concerning. Checked the laser. And then we went towards the anterior part of the eye to try to remove this capsule, which, like I said, was now sneaked down 360 to the iris. So that was visco dissecting there. And then first tried to just pull the capsule out, but it was really adherent to the ciliary body, and I didn't want to cause a ciliary body attachment, especially not 360. So I tried to pull as much as I could without actually causing a detachment, and just get a little further away and at least break the synechii. And then we decided to segment it and remove just as much of the capsule as we could, so at least you couldn't get kind of circular contraction.
And Suze, when you were inside the eye for this part of the case, or before this part of the case, had you seen any kind of anterior loop PVR here? Obviously, that would have been an earlier surgery where you did the retinectomy, where you took that off. But did any concerns there, like cyclitic membranes back there? Obviously, we can see there's adherence.
We didn't see any, but I think it might have been difficult to see as well.
A total, like, Monday morning quarterback. For me, the lens capsule is not my friend. Even after in that initial surgery or two, the notion that this eye could, later really support an IOL and in the sulcus, it's not going to help. And here, even though you've done a 360 retinectomy, you really worry, as you pointed out, about traction on the ciliary body and hypotony and kind of losing it at the end. So, I tend to get the capsule out, surgery 1 or 2 at most, because it starts doing this type of nonsense.
Yeah, I think in retrospect, maybe we would have removed the capsule, knowing what we know now. But at the time, we were very optimistic.
Well, with your outcome thus far, I would be too, but mine don't look this good.
I don't know about that. see. And then we just checked again, and we ended up putting C3F8 in here as well instead of the silicone oil to hopefully save him another surgery. And then we sutured, and that was it. And I have some pictures.
Great case, great job. Attending and fellow, great job, Hassan.
Really nice job, challenging.
Oh, I had some discussion questions, but I think we're at 7 too, and running into.
You're okay. Go show us the pictures, and then I think
yeah,
there are a couple things for us to chat.
Attached under gas, and then this was it at post-op month 2. Still looks attached. Looks good.
Look at that EZ. There's an EZ there. That's awesome.
That's amazing.
It would be great, but he actually, I think, from the original rupture, has a large macular scar.
Oh,
so he's still counting fingers, hand motion. But the retina is attached.
Question to the group: what gauge do you prefer for PVR surgery? 23, 25, or 27? Sumit?
I'm 25, pretty much across the board.
Stephen?
Same, 25.
Anyone go to 23 gauge for PVR specifically? It's the question from the audience.
The only reason I do that is if I'm taking oil out, just to make taking the oil out faster. But I think all the instruments, and as Peter mentioned, if I'm doing a lensectomy, maybe I'll do 23. But otherwise, 25 for all the instruments, all the forceps I think I need are 25.
Yeah, and I think you use what you need to use and what you're comfortable with, but you can, if it's a valve 23, then you can still go in with 25 gauge forceps if you needed something smaller. So I don't know if it really matters what you're using to kind of get into the eye, but if you want to use the cutter for something more finessed, then the 23 cutter can get a little bigger. So yeah.
Oh, and then one other thing that we talked about a lot, we used methotrexate in the infusion for this last case. We did not end up giving him the series of methotrexate injections. I don't know if anyone has any other thoughts or anything they would have done differently for that with this patient.
How much did you put in?
I think it was 400 micrograms in the bag. I can't remember. Maybe somebody can help me remember the.
Yeah, we put it in there. So 40 milligrams.
40.
Yeah. So we call it up. We call it up from the pharmacy, and then it gets put in by our nurses into the bag. And usually you don't need more than one bottle, but that's what we'll do there. And then many of us here have been, especially for these bad PVR eyes, been giving methotrexate post-operatively. I'd say I know Steve Sanislo does. I've been doing it pretty regularly now, but
yeah, I've started too. I think it's important when I talk to patients, say that it's definitely investigational at this point, and it's not a miracle drug, right? But it's kind of heroically doing what we can to slow things down. But yeah, it's at least gives us a chance of slowing the process when it started.
Are you doing it for all your PVR cases? Or how are you
the ones that I
deciding
know
who
that are
gets
going to
it?
detach. So I think that really bad PVR, I think that if there's high risk features or recurrence, or if there's hemorrhage that I'm seeing, at the edge of retinectomies, that type of thing. So I don't know if it's just natural history, they just got out of that PVR cycle. But there have been some doozies that we're going to go the wrong way, that either I've delayed when they redetach, I feel, or we've kind of gotten out of the redetachment. So I can show you some really nasty pictures, and then suddenly everything kind of contracts into little ropes, and then they hold. But I think we've been, I think we're more aggressive with it because it seems to be positive in some cases. So
I think the idea of putting it like in the infusion is really cool. It'll be interesting to see sort of like what the results of that are if you guys are looking at.
I think that's, again, that's really old school stuff, like putting additives into the infusion, whether it's, TPA or heparin or whatever. So I think if those cases you're going to put methotrexate into the infusion, then you probably need to be giving them post-op injections, in these oil-filled eyes anyway. So let's continue. That was great. That was uplifting because it looked really good. We'll move to two second-year fellows who have the fortitude to manage PVR now on their own. So Danny Mamo is second-year fellow at the Cole Eye Institute. Danny was a resident at Minnesota and is finishing his fellowship now at Cole and will be joining the faculty at the Cole Eye Institute. And next year will be one of the mentors here for COBRA.
Let's see how this case goes before we say things.
You've already hired him. I think it's all good now.
It's contingent. It's contingent.
It's not contingent. Danny, take it away.
Thanks, Prithvi. So just two quick slides here. I'll try to speed up in this sake of time. The title of this one is Respect the Hyaloid and Don't Do Meth. This is a 45-year-old woman. She has a history of a severe chemical injury after an explosion while self-manufacturing her own meth. And then she developed limbal stem cell deficiency from that. And then she had a very complicated anterior segment history. Ultimately, at an outside institution, she received a K-Pro and a VIT at the time of the K-Pro. And then she presented for a second opinion after developing Candida endophthalmitis. So she had antifungal treatment that included intravitreals, an explant of the K-Pro, and a PKP. However, afterwards in her postoperative course, she developed an RD, as noted on B-scan. And you can pay attention to the B-scan here and think about what you think these hyper-echoic lines are and the configuration of the retina, and we'll see in the video. So we elected to undergo a TKP, VIT, PKP, and then a Gunderson flap that the cornea surgeon wanted to do for her limbal stem cell deficiency. So definitely heroic surgery. I believe at the time of surgery, I should have had this in here, but her vision was LP. So I guess the first question is for the faculty, how do you guys determine whether to give an eye a chance or give up? And what are your conversations like with the patients?
So Danny, just to confirm, we have an eye that just survived candidal endophthalmitis in the setting of a K-Pro, a previous, and so it has you don't have a view in, correct?
No, hazy view.
Right, and her vision at best is LP. And what's her pressure?
So her pressure, well, we're going to see. The pressure was very soft.
Oh. All right.
We don't know what the pressure is, right? Because she has a K-Pro already.
Right. So you're looking for just like
PKP at this point, but her pressure was very low.
I think the first question I ask myself is how I'm feeling. Have I had a milkshake for lunch? At the end of clinic day.
And what's the status of the other eye? Because if she was a meth, like both corneas are probably affected, right?
The other eye is better, but not great. Also has cornea issues.
Young
like
patients,
if her other eye was totally normal, I may just tell her like do nothing. But if her other eye is not normal, then this is like her spare tire, and a spare tire that's LP is still better than a spare tire that's NLP.
I agree with that. I agree with that sentiment. I think I'd give it a go.
Totally. That what Carolyn said, I think is key. That's how I'd address this as well.
So she was very motivated. I think these are tough cases, but she was very motivated, came to us for the hope that we would do everything we could. So we gave it.
Danny, I want to say that I'm impressed with the amount of crystal meth images you have throughout this whole presentation, how easily you put them in. I'm a little worried, but
I wish you'd asked me just a little bit before, because I was going to put I have a photo of Prithvi dressed up as
oh, nice.
I gotta find it. I'll show you guys.
All right.
Oh, that was his previous job. That's good.
Can you guys see the video?
Yes.
Yes.
Okay, so there's a few different types of temporary keratoprosthetics you can put in an eye. So our cornea surgeon had already taken the PKP out and sutured this TKP on the eye. This is a Landers TKP, which has these holes that you use to suture. So previously it was reported that you could use these suture holes to put the infusion in to maintain pressure before you put your trocar ports in. So we tried that, and like a lot of things that look good on a publication, they don't really pan out as well in real life. this infusion was kind of leaking throughout underneath the holes of the TKP sclera interface. So it didn't maintain pressure as well. So the eye was still very soft. And you're gonna see how difficult it was to get the trocar in here. And then
one of the things I'll just jump in as you're doing this. I did a case like this right after finishing fellowship. It was a really fun experience. If you have a case where they have an old PKP that's totally like non-functioning or no view, you want to make sure if you're the retina surgeon that you put in your infusion line before they put the TKP on, because it's really hard to get something into an eye when literally anytime you touch it, there's gaping wounds across the front. I mean, this is almost like an open sky. These things are so not sealed, it's not even funny.
Yeah, it was very leaky. So here you can see all the manipulation. The already detached retina came more forward and was literally right behind the TKP. But this allowed us to put viscoelastic tamponade in the eye, which allowed the eye to pressurize more, which allowed us to finally get our ports in. So we ended up switching almost right away and putting a 6 millimeter in the eye. And then we also tightened the TKP to prevent further leakage. And then another teaching point here is, usually we, I can just rewind a second. Usually we measure from the limbus to know where to go, 3.5 or 4 back, but we don't have a limbus in this case. So if you just think about the corneal diameter as 11 or 12 and half that, and then add 3.5 or 4, if you measure from the center of the TKP and go about 9 or 10 back, you should be around where the pars plana is. So I think in this case we went around 9. Now initially we only used regular trocar, good size trocars here. We kept getting retina. So some techniques with retina, as you saw we did there, are to enter with a trocar blade and pierce the retina, and then you have an opening for your instruments. However, this kept happening, as you'll see here. So we're doing some anterior dissection, but as you can see, our instruments keep getting caught up. So we decide to replace these right away almost with 6 millimeter cannulas to prevent that from happening. So as you can see, the retina is very drawn up. The retina, if you remember the B scan, the 3 o'clock and 6 o'clock retina are actually just totally stuck together around the equator. So we start our dissection just under direct visualization to show you how anterior this retina and adherent hyaloid and PVR was. And then we transition to the posterior view and doing a bimanual technique here with a lighted pick and forceps. To basically dissect this hyaloid that's stuck onto each other and part of the C.
That's gorgeous. That's really, really nicely done.
And then we switch hands here and complete the process. And then as we release here, as expected, the hyaloid was still completely down. So I think in that first surgery, either there was a lot of vitreoschisis or just the hyaloid wasn't fully lifted. Giant blood clot there that we take. So here we have massive posterior hyaloid all the way basically from the posterior pole anteriorly. That's very adherent and causing a lot of traction. So right away, our goals are to dissect the posterior hyaloid maybe to around the equator and make room for PFO. So to do that, I'm also doing a bimanual technique, grabbing the PVR membranes with a max grip and then dissecting with the lighted pick. And then you kind of like push away on the retina with the lighted pick and can gently pull with the max grip or not so gently.
That PFO down really makes what you're doing now that much easier, right? Like it really creates that third hand for you, especially for this type of like broad membrane removal like you're doing.
Exactly.
You're just pulling like ropes and ropes of membrane out. It was great.
And here superiorly, here superiorly, pushing down on the retina with the lighted pick and pulling with the max grip, this is my actually first time doing this, and it was a good tip by Sumit to do this superiorly, and it helped a lot. So then we decide to proceed. We think we've dissected enough anteriorly, so we proceed with 360 retinectomy. So using diathermy here, and then start cutting and making it as much as possible, excising the anterior retina to prevent future cyclitic membranes and, well, I'd say prevent hypotony, but we're already there. The thing that was tough here was normally when you're doing this, in another case, you might depress to bring the anterior retina into view better. But in this case with the TKP, it's actually almost impossible to depress well, because then you just increase the gap between the TKP and the sclera, and it would mess up with your fluidics and ruins your view. So just doing the best we can to dissect the anterior retina. There's a subretinal PVR band that was nicely lifted with a max grip forceps.
Danny, one of the things you could do when you go to air in this case, and after you put some viscoelastic behind the TKP, you can do a vitrectomy under air for some of that peripheral stuff. So if you really needed to get it, you can use I don't do it often, but that's one of the tricks you can try. It's a different feel, but you can usually suck and aspirate that necrotic anterior retina, and it will just usually peel off. You don't actually have to cut it.
That's a good tip. When you do that, do you have to use like low vacuum?
Yeah, you start lower, I get the air all the way down, so everything posteriorly has settled, and then I go for the anterior stuff and just gently kind of, you can either use a soft tip, but I like the cutter just in case, with the just so in case I have to cut it. And you can do it with the TKP, but you have to put viscoelastic behind it. It's gonna, you'll see, I'm sure when you go to air, you're gonna see this condensation on the TKP. But that's the nice thing, is you can put viscoelastic on it, and actually you can actually get to the periphery.
That's a good tip. So here I didn't show this step, but we actually had to freshen up our superior retinectomy and bring it more posterior because of how hard it was to view the superior retina, because of when I'm tilting the eye superior, like torquing the eye, it kept gaping the TKP sclera interface, and we kept losing the fluidics. So we actually couldn't see my initial superior retinectomy well, so we made it more posterior to get it into our view and almost totally primary gaze. And I think so here I show what happens when I'm tilting the eye superiorly. So we lose that view. Then we add PFO and do 360 continuous laser. Okay, so now eventually you want to do fluid air exchange and then do oil, but we still have to have our cornea colleague take the TKP off and put the PKP on. So what do the attendings like to do in this case? Do you go to air and then have the cornea attending do the PKP, or do you put oil in and then do the PKP?
I'll take this. The other option is you leave it with PFO, let them do their graft, and then you go in and do a direct PFO oil exchange. Sometimes air, the eye filled with air isn't easy for them to do their procedure with. So it's another option.
And when you've done that, the view is under the PKP, the view is like fine to do the direct exchange.
Yeah, I mean, it's unless there's bleeding or something, it's a fresh graft, but you'll have, it's just a bad view at the end, but usually it's enough because it's a fresh graft to see what you need to do.
I tend to just leave it under air, and I've talked it over with the cornea people I've worked with, and they're fine. Once they get the first suture or two on, it's usually not a problem, because then they can put some viscoelastic in. And so I tend to do it under air, but you could do any of these techniques. I think you could do it under oil too. It's just, what's the cornea surgeon comfortable with is what I usually say.
Yeah, I did retention sutures and oil in the case that I did.
So we were worried about just having a bad view. So we did fluid air exchange. Obviously very carefully. We have a 360 retinectomy. So slowly, much slower than shown here, going around and aspirating the fluid along the retinectomy edge. We lose our view. So we actually put viscoelastic behind the TKP to help improve the view. And the view improves to finish the fluid air exchange. And then we decide to do an almost complete oil fill. And then we leave some air at the anterior portion. And then our cornea attending does the PKP. And then we insert more silicone oil at the end, use a soft tip to aspirate the anterior air, and kind of just go by feel, to be honest, about how much silicone oil fill we had, just topping it off there. And then the cornea attending did the Gunderson flap. Oops, sorry. So that's the end of the case.
Gorgeous.
What a great case. Both of you, nice
Danny
job.
did a fantastic job on it. Unfortunately, she didn't do so well.
I was talking about the cornea surgeon. I wasn't talking about you guys. The cornea surgeon did a great job.
So,
did the eye not do so well?
No,
I think she still has her Gunderson flap, right? Or no?
Yeah, she still has the flap, so we have no idea what the retina is doing behind it all.
The cornea, sorry, the retina didn't look all Swiss cheese after the endophthalmitis, right? Like it was actually remarkably, had some floppiness to it, which is good for her, I guess.
I had two of these back to back. I did. Danny, did you do the other one too, where the retina was Swiss cheese?
Just
did that one. That one was endophthalmitis, and that one, the retina was Swiss cheese. We were not able to reattach these, so I had the pleasure of doing that one and then this one, and this one went much better.
Yeah. So that's great. And so let's try to tie it all together with our last case this evening. Kapil Mishra is a second-year retina fellow at Stanford. Kapil did his residency at the Wilmer Eye Institute, and upon completion this summer, he'll be returning to Baltimore to be chief resident and assistant head of the trauma service there. So Kapil is going to show a case that he did with Steve Stanislav. Stephen, moderate.
All right, take it from here, Kapil.
Thanks, Prithvi. So thanks to the East Coast people for sticking it out. So this is a 86-year-old male with moderate NPDR. He has macular edema on the right eye. He was undergoing anti-VEGF injections and is just presenting for kind of his regular follow-up in retina. He has severe POAG. He's presenting for DME follow-up. His right eye is 2100 pinhole 2080, which is at his baseline. His left eye, which is the eye of concern, dropped to count fingers from about 2150, and he hadn't noticed a change. And then when we actually look at the exam, this is the ultra wide field photo of the left eye, where he has a retinal detachment from about 1 o'clock down to about 6 o'clock. And he's got this really interesting focus. It almost looks like a knot here in the temporal mid periphery. And this is just showing just an OCT in the macula showing him detached. And this is how he looked before. This was just 1 month ago, where he didn't really have, I guess, the most in-depth peripheral exam. So it's hard to say what was out here just 1 month ago, but this is clearly a big progression. And I just wanted to quickly ask the faculty what they thought of this kind of little knot of this focus here. Like what immediately jumps out to you, or what are your thoughts? Actually, maybe I should show some more imaging first. So this is the FA. This is early and late, where it shows some areas of blockage, but really just some leakage in this area, possibly due to the traction just in that area. And the B scan is interesting. It shows obviously the retinal detachment, but it shows this thickening in the retina that also appears subretinal, but not really involving the choroid. So it's lifted off in this area. So unfortunately, this patient was getting injections in the right eye and developed a post anti-VEGF endophthalmitis. And so it delayed the surgery in this left eye. The surgery was scheduled to go, but he had to undergo a vitrectomy in the fellow eye because he had endophthalmitis with LP vision, but it at least gave us a shot to kind of see the progression of this area, where you can see it a little bit more here, that it looks like there might be a slip break right here. And this extends as this area opens up as well. So the slip break seems to open up too. And so this obviously needs surgical repair, but we wanted to rule out any inflammatory or infectious causes. And just to step back a little bit, the infection in the other eye was certainly from an anti-VEGF injection, because the cultures grew coag negative staph, and it's not like he had something systemic going on. But we did undergo a systemic workup just to rule out TB, syphilis, sarcoid, just some of the inflammatory causes just before going into this eye. So for the surgical plan, we elected to go for a 42 band with a pars plana vitrectomy. The patient is already pseudophakic. And so just showing some parts of this buccal under the scope. And due to poor dilation, we put in iris hooks. So now we're doing a core vit and looking around this area. You can see the detachment here. We decided to, so we're continuing to shape over it. And with that slip break, we're taking out some of this sclerin to see if it can settle down a little bit more. And then we put diathermy around here in anticipation of kind of just to help with hemostasis, but just to be able to use forceps to grab some of this and send it for pathology, because we still weren't totally sure what this was, but it was very gummy and very friable. And just anytime we tried to grab it, it would just totally shred and we weren't able to get anything. And so we decided to go forward with an excisional biopsy and take out the whole thing, extended this retinotomy, more sclerin came out. And then this is the focus here that we're using. And so there were a couple of different options of trying to clean around this focus. And we decided to use scissors because by using the cutter, we didn't want to inadvertently take up, a lot of this tissue and not get a good enough sample. So we used horizontal scissors and just kind of slowly went around this focus, and didn't have to do bimanual in this case. And then we can kind of see this sort of thick, nodule or granuloma or subretinal PVR, and we sort of flip it over with the light pipe, and we're cutting just the last little bit. And so it's a pretty sizable chunk, and this was just not going to fit out of a regular trocar. So we use a 19 gauge MVR blade to extend this sclerotomy. Do a little bit of cautery just at the edges, and then we're using foreign body forceps to try and gently bring this back out.
You might consider a more circumferential opening in case you had to open that more rather than a radial.
Yeah, it's a good point. We felt like we had space here in the pars plana to keep it radial.
Prithvi, I think the other reason we went radial is because the original sclerotomy, when you make a normal sclerotomy, it's radial in orientation. So we just didn't want to make an X or a cross.
So it just kind of comes out, but it was a good enough sample to be able to give. We put PFO down, more sclerin comes out. And then we decided to create a sectoral retinectomy here because there's still some traction coming up here. And this is all anterior retina. That will be ischemic due to losing its posterior supply. And so I know we had all of these, and then we closed this sclerotomy, just the large one, just to make a new one. And I know we had a lot of discussions of the edge of the retinectomy and the horizontal meridian, but all of this retina was really healthy sort of throughout. And so just keeping this sectoral, even though this is below the The 3 o'clock meridian or the horizontal meridian, it's just taking a little bit that we needed.
Yeah, I think this is a different situation though than some other ones, right? You said it right. The rest of the retina is going to lie flat, and you're going to get, the most important thing here is to get the anterior retina that's causing some traction. So you're going to be fine in this scenario.
Right, right.
Yeah, I always go by the adage that you never go less than 90 degrees in a retinectomy, but this was such a focal area that it was involved. And so it just didn't make any sense to make a bigger retinectomy.
And you've also got a good buccal support there. And then I assume really good thorough shave vitrectomy and healthy retina. So all those things make the kind of traditional thinking about, oh, it's got to be 180 a little different, I think, in this case.
But there's a question about an ERM that was seen on the OCT, and did you guys want to like address that, or did it not look that significant?
That's a great point. It didn't look that significant, and it was kind of more like we wanted to achieve the surgical goals. I think if there was a lot of traction that seemed to be extending posteriorly, then it's a great idea to even peel the ILM in certain times. But because it was so focal, it laid nicely without doing anything posterior.
And the audience, feel free to chime in. Would anyone in this case, let's say there wasn't an ERM seen on OCT, but you have this more posterior temporal retinectomy, would anyone just electively peel ILM anyways in the macula? Any takers?
What would you do, Prithvi? Would you have peeled?
I don't think so. But I don't think so. Not in this case. I think that surgical goals would have been met. If there's something that happened on the, if we had to go back for something, then I think that's something that I've been thinking about more. Whether peeling the ILM, at least in the central macula, might give you less scaffold for PVR to crunch the macula. Maybe. I don't think there's any proof to that. But if I had to go back a second time, I think I'd consider ILM peel in the macula.
Yeah, I mean, the thing that's going to detach this retina is going to be any proliferation along the edge of the retinectomy edge, right? So I think I would have avoided peeling the macula because it looked pretty good. It flattened pretty well.
Yeah, it looked really good. Yeah.
The anatomy looked well. I mean, I would have. So how about oil versus gas? Can I ask that question? I mean, you guys used oil. Could make an argument for gas. So what was your decision for oil here, Kapil?
It's a good point. I actually think you could probably go either way. I think one of the things is we didn't 100% know what we were dealing with that nidus, and I think oil possibly being a little bit more stable, I like over the long term. I think you can argue either way, but oil worked really nicely here. What would you have done, Sunil?
I think it's for the point you made of not knowing what that was. I think oil kind of makes sense to me. I would have done C3F8 probably. That looks. You're gonna tell me I'm wrong here, but I mean, looking like that, it looks more fibrotic to me, at least when you pulled it out. So I think I feel pretty good, at least looking at this, that it's probably PVR. But I think if there's any question, oil's easy and you can always take it out. I may have given it gas, but I would have sat there and hemmed and haw about it probably for a good 10 minutes until the fellow already put the oil in. We were out of the guy.
Yeah. Well, I mean, you're totally right though, of it looking fibrotic. So paths showed that this was retinal tissue with associated glial and vascular proliferation, although we didn't really appreciate much vascular proliferation. And they said that these path findings supported a PVR process and that there was actually no significant inflammation seen. So it was interesting. I just wanted to quickly ask this. I haven't been looking at the chat, but this looked like there was no really pre-retinal PVR component. This is an elderly gentleman with a PVD, and this was all subretinal PVR. I'm just curious what your thought process when you see this in the clinic is. Was there a slit break and then this developed into just having a nodule of subretinal PVR, or what do you think may have happened, or did the path not actually maybe shows that there was something else going on? What are people's thoughts?
I don't think this is, so I think it's a strange appearance, but it's not unusual. I would say that I think exactly what you said happened. I think you had a slip rank, and the PVR proliferation can occur however it wants to. And so in this case, he was lucky. It was focal. It was full, it's contraction of the retina plus the subretinal component, right? If you think about some of the things that happens with PVR, you get retinal foreshortening. This is very, very focal foreshortening. So that's what I think that occurred. I agree with your buccal use. I know there's a couple of points here in the chat. I'd stick, if you're going to do that kind of retinectomy, that kind of temporal retinectomy there, I would have the buccal on. That would be an important part for me. But I'm more traditional in my way of thinking about it. So that I agree with what you guys did. I thought you did the right call.
Scott Walter brings up an alternative diagnosis as this could be what we'd call a vasoproliferative tumor as well. It does have it doesn't to me look just typical for PVR. It did have that contracted nidus, and even on the FA there was leakage focally in that, so there was probably a proliferative process of some sort. It's not typical for your classic vasoproliferative tumor, but it's there. And I think Scott also brings up a point that if this is a vasoproliferative tumor, secondary epiretinal membrane formation is not uncommon. So thinking about at that point, taking ILM, it isn't wrong either. So something to think about. So and Danny, PARG is another term that the purists will argue better defines what a vasoproliferative tumor actually is. So the pseudoangiomatous gliosis, but we were talking about the same thing.
And since you put in oil, you're going to have to go back, right? So if the ERM gets worse, you can monitor when you're back in. You could always peel at that point. But I totally agree with Sunil and Steve and Kapil in this case. I would absolutely leave the buccal on, especially because you may get some more proliferation. And so I'd want to have it mid-high or high, so you're really supporting that vitreous base, and hopefully you can avoid additional retinectomy and additional problems. So this is a case where I would certainly leave it on.
Another reason for oil is the patient's 86, I think. And so if you wanted him to position that type of thing, I think oil, could be easier.
Yeah.
I think his oil's out. I'm pretty sure his oil's out, and he didn't have any further anything. Actually, it looks great. But I really think it probably is some sort of vasoproliferative tumor or something, because it just didn't feel at all like subretinal PVR. I mean, in the 20 years that I've been doing this, usually when you grab something under the retina, it's usually pretty fibrotic, and we can grab a little bit of a band in it, or even a membrane, and this giant membrane all comes out. But this was like just grabbing at like cottage cheese or something, or gelatin. The forceps would just go right through it, and that's why we had to make that cut around it and remove it on block. So I was a little surprised when it didn't show anything interesting on the pathology, but it certainly did not act at all like PVR in terms of the feel of it and the touch of it.
Our next case is going to be a floaterectomy, because that's the
that's clearly what we should we should
focus our next section on floaterectomy.
Maybe just on maybe we'll just do vitreous hemorrhages, something like oil outs. We'll do oil outs. Let me congratulate the crew that did everything here, the attendings. Boy, you're all patient. Congratulations. The fellows, boy, you're patient for listening to your attendings, tell you all this bad stuff to do. Thank you for the audience to hanging around so long.
When's our next session, Neil?
Our next session is April 25th. Please join us. We are going to probably talk about trauma and intraocular foreign bodies, but we may change it up because, if you have some ideas, please come forward to us. This is made for fellows, young attendings, to kind of figure out what tips and such. So, please send us any comments. Prithvi, any last words? I'll give it to you, man.
All good. This is really great. Proud of all these great surgeons and what they're doing. So keep it up, everybody.
And thank you to everyone in the chat for their comments. And we really enjoyed the discussion. I think we all can learn from each other, and it's great to get all these ideas. I think it's really important for us to hear other opinions and to know that there are multiple ways to do some of these things. So Thank you for everybody for taking part. Have a lovely night, everyone. Please be safe. We'll see you April 25th. And thank you again to Bausch for their support for this series, which we're going to continue on hopefully for many years. Have a great night, everybody.